discussion where we are saying that a child with a chronic right chronic otitis media. Then after the child returns from the laryngotomy and the placement of ear tubes, which intervention is appropriate? Yes, applying gauze dressings, positioning the child on the left side, positioning the child on the right side, applying warm compresses. Yes, so guys, we have agreed that the correct answer is option C. Positioning the child on the right side. The child has right chronic otitis media. We are placing them on the right side so that at least the drainage can come out. Okay. So, otitis media is characterized by the inflammation of the middle ear that is associated with fluid accumulation, most commonly due to poor function of the Eustachian tube. Guys, the structure and the review of the ear will just be popping up. You can try to review all the sections, all the structures of the ear, starting with the external ear, middle, and inner ear. So generally, otitis media can be acute or chronic, or it can be suppurative or secretory, or both, guys. So for the acute otitis media, there is disruption of the Eustachian tube patency, usually of short duration, less than 3 weeks. Whereas the chronic otitis media, the disruption of the Eustachian tube patency usually is longer than the 12 weeks. About secretory otitis media, you're saying that this one is majorly a viral infection or could be allergy or barotrauma. Whereas the suppurative otitis media, bacterial infection with pneumococci or group A beta hemolytic streptococci, staphylococci or gram-negative bacteria. For the chronic secretory otitis media, it is characterized by someone having an adenoidal tissue overgrowth, edema, chronic sinus infection, or inadequate treatment of an acute suppurative otitis media. Whereas for the chronic suppurative otitis media, we have inadequate treatment of otitis media episodes or infection by resistant strains of the bacteria. So otitis media can happen with effusion, okay? So here we have persistent inflammation of the eardrum due to thick or sticky fluid accumulation and can lead to chronic otitis media if the fluid becomes infected. We also have recurrent with so we normally term it as recurrent when you have more than 3 episodes, okay? So we have 3 episodes occurring within 6 months or 4 or more episodes occur within a year. We call that recurrent otitis media. Note that acute otitis media is an emergency. It's an emergency in immune-compromised children. Okay, children suffering from HIV, children with cancer, or children who have undergone severe infection that is limiting their or impairing their immune system. Also, children with other cancers like Hodgkin disease could also be as a result of this, or children receiving chemotherapy, okay, or who have undergone organ transplant, right? Great. Let's look at pathophysiology. So in pathophysiology, they're saying that this disease differs depending whether the otitis media is either suppurative or secretory. So for this suppurative form, the respiratory tract infection or allergic reactions or position changes normally allow the nasopharyngeal flora to reflux through the Eustachian tube and then colonize the middle ear, resulting into otitis media. Whereas the secretory form, we have obstruction of the Eustachian tube, promoting transduction of sterile serous fluid from the blood vessels in the middle ear membrane, resulting into otitis media. The major causes in terms of microbes, the bacteria could be Streptococcus pneumoniae or Haemophilus influenza. As for the virus, it's mostly the rhinovirus or the respiratory syncytial virus. Okay. What about the risk factor for otitis media. So I've tried to summarize for you a table showing the factor and how it can cause otitis media. And one of the notorious suspects here are the allergies. So allergies normally lead to inflammation and congestion of the Eustachian tube, which can impair proper drainage of the middle ear and therefore create an environment conducive for bacterial growth, resulting in otitis media. We also have lack of human milk feeding. Okay, so as you all know that human milk contains antibodies that can help protect against infection. So lack of breastfeeding might reduce the transfer of these protective factors, potentially increasing the risk of infection such as otitis media. For the cleft palate, I find that a cleft palate can disrupt the positioning of the eustachian tube and ventilation of the middle ear. So this leads to fluid accumulation and increased susceptibility to infection. As for the young age, okay, so why are the young vulnerable to this condition? Young children have shorter and more horizontal eustachian tubes. This makes it easier for the bacteria to travel from the throat, okay, to the middle ear. This increases the risk of developing infection, of which otitis media is one of them. We also have another risk factor in terms of bottle feeding while in supine position. So bottle feeding while the child is lying can lead to pooling of milk and formula into the back of the throat. So this one increases the risk of bacteria entering the eustachian tubes and causing infection. Use of pacifiers has also been implicated. Frequent pacifier can contribute to the misalignment of the eustachian tube, impairing proper drainage and increasing the likelihood of fluid buildup and infection. We also have children who are taken to day centers or attending are likely to develop otitis media. Why? Okay, we're saying that daycare centers can be breeding grounds for the infections due to close contact with other children. So exposure to respiratory infection in such environment can increase the risk of otitis media. Okay, household smoking can also be a risk factor. So if you are a second-hand smoker, this one normally irritate and inflame the eustachian tube, impairing the proper functioning and increasing susceptibility of infection like otitis media. Next, we have family. So family history of the middle ear disease. So we have genetic predisposition can play a significant role in the structure and function of the eustachian tube. So this potentially increases the likelihood of ear infections like the otitis media. We also have a risk factor of the craniofacial abnormalities such as cleft palate. So structural abnormalities in the face and mouth can impact the eustachian tube function and the ventilation of the middle ear. This normally leads to fluid buildup and increases the risk of having otitis media. Gastroesophageal reflux disease is also a condition of the GIT, and it has a correlation with also the otitis media, in that reflux of the stomach contents into the throat can lead to irritation and inflammation of the eustachian tubes, which contribute to ear infections. We have weak immune systems due to immune deficiencies. So immune deficiencies compromise the body's ability to fight infections. This makes individuals more susceptible to bacterial invasion and development of infections such as otitis media. Lastly, we have common cold, and they're saying that respiratory infections like common cold can lead to inflammation and congestion of the eustachian tube. This impairs the drainage and creates conditions favorable for bacterial growth, resulting into otitis media. So we have come up with a mnemonic for the risk factors of otitis media. And we have BP, baby pack and pack grab. So B stands for bottle feeding in supine position. Okay. Allergies, that is A. The second B stands for bottle feeding without human milk. The Y is for young age. P is for the pacifier use. A is for the attendance. C is for the craniofacial abnormalities, common cold, reflux disease, abnormal family history, and gastroesophageal reflux disease. So we have the Pepibac Pack Grab as the mnemonic. Thank you. So let's look at the incidence. Incidence, you're saying that otitis media is the leading reason for acute care visits. It's also the most common reason for antibiotic administration in children, and it places or increases that risk of antibiotic use and misuse, right? Great. Otitis media is commonly occurs in infants and children. So we have approximately 80% of children will experience at least one case of otitis media during their lifetime. Otitis media is the most common condition requiring medical treatment in children younger than 5 years. So otitis media will peak between ages 3 months and 3 years. The incidence normally subsides after age 8, okay? Otitis media is more common in males than females. And the incidence of otitis media is higher in Native Americans compared to the rest of the population in US. Otitis media is the most common during winter months, and it normally parallels the seasonal increase in viral and bacterial respiratory tract infections. So what are the complications of otitis media? So now let's look at the complications of otitis media. Number one, we have spontaneous rupture of tympanic membrane. So pressure within the pressure that is trapped normally leads to fluid build up until the eardrum bursts, releasing the fluid and providing relief, hence having the spontaneous rupture of the tympanic membrane. Number two, we have persistent perforation. So it's important to know that when the tympanic membrane doesn't heal after rupture, it leaves normally a hole that can cause ongoing ear problems. We have mastocytitis. So infection spreads from the middle ear to the mastoid bone, causing inflammation and potential damage. Okay, so we have the tenderness on the mastoid bone. Someone will be diagnosed of mastocytitis. Okay, so palpation, tenderness on palpation. Meningitis is the next one. Okay, so infection can spread from the ear to the meninges. Remember, the meninges are the protective layers that are normally found around the brain and the spinal cord. Okay, so when they get there, they lead to the inflammation of the meninges, resulting into meningitis. We also have cholesteatomas. We have repeated infection or persistent perforation can lead to abnormal growth in the middle ear with potential damage. What about the abscess? So infections can lead to formation of pus-filled pockets, causing pain and other further complications. Septicemia. How does septicemia result? Remember, bacteria from the middle ear can enter the bloodstream, and when this happens, it causes a severe systemic infections. We have lymphadenopathy, and lymphadenopathy saying that infection can cause enlargement of the nearby lymph nodes as the body immune system kicks in. Okay, we also have another complication, leukocytosis. We have elevated white blood cell count as the body tries to fight the infections. We could have permanent hearing loss. Okay, so damage to the structures in the ear or the auditory canal could lead to permanent hearing loss. Okay, what about the tympanosclerosis? We normally have the scarring of the eardrum, okay, due to repeated infections potentially affecting the hearing ability. We have vertigo as another complication. So infection or inflammation affecting the inner ear can disrupt the balance and cause a sensation of spinning, okay? We also have increased risk of type 1 diabetes, guys. So how is otitis media related to type 1 diabetes? Well, there's some evidence suggesting that there's a potential link between frequent ear infections and development of type 1 diabetes. And one of the major reasons is because of the immune system modulation. So this theory says that repeated infections including ear infection, might affect the immune system regulation and response. So this immune dysregulation could potentially contribute to the development of autoimmune infections such as type 1 diabetes, where the immune system mistakenly attacks the insulin producing cells, the beta cells, okay, in the pancreas. Also, we could also be having shared genetic susceptibility, okay? So there could be a shared genetic factors that predispose individual for both ear infections and type 1 diabetes. So genetic predisposition plays a significant role in the development of autoimmune infections, and some genetic variants might contribute to susceptibility for both conditions. We also have early life exposures. Some researchers speculate that early life exposure, such as infections, might influence the development of the immune system and contribute to the risk of autoimmune diseases like type 1 diabetes. We also have the gut playing a critical role in the immune system development and regulation. So disruptions in the gut microbe could be influenced by infection, which might impact the immune responses and potentially contributing to autoimmune disease. So let's look at assessment, and assessment will be starting with history, where we look at the history of the upper respiratory tract infection, allergies, severe deep throbbing ear pain, especially when lying down. Do you have a history of dizziness, nausea, vomiting, tugging or pulling at the ear, trouble sleeping, crying and fussiness, trouble hearing and responding to sounds, and loss of balance? Also could have fever, drainage of fluid from the ear, headache, loss of appetite. These are some of the history that you are likely to get from the client, some of the complaints from the patient, okay, suggesting that someone could be having otitis media. We also have acute secretory otitis media, where there could be sensation of fullness in the ear, could be popping or crackling or clicking sounds when swallowing or moving the jaw, okay? Or this could be a perception of an echo when speaking. In case of tympanic membrane rupture, the patient could present with pain that suddenly stops, or there could be a history of a recent air travel. What about the physical findings? Okay, we could have sneezing and coughing. Okay, the patient could be sneezing and coughing. The patient could be having middle to high fever. We could have painless purulent discharge, and that could be in the case of chronic suppurative otitis media. We'll also be having obscured or distorted bony landmarks of the tympanic membrane. And this is majorly in acute suppurative otitis media, okay? Also, the tympanic membrane retraction could be there in acute secretory otitis media. We could also have clear or amber fluid behind the tympanic membrane. We also have the blue-black tympanic membrane with hemorrhage into the middle ear. And we could also be having pulsating discharge with tympanic perforation. You also could also be having conductive hearing loss. Okay, so this one varies with the size and the type of the tympanic membrane perforation and ossicular distraction. We also be having decreased eardrum mobility, and this is there or dominant in otitis media with effusion. What if the patient has chronic otitis media? The patient could present with thickening or scarring of the tympanic membrane. The patient could also present with decreased or absent tympanic membrane mobility or cholesteatoma. Okay, so those are the different ways in which you can be able to assess and the signs and symptoms of otitis media. Let's now look at diagnostic tests. And in diagnostic tests, we can start with laboratory, followed by imaging and diagnostic procedures. In laboratory, we normally have culture and sensitivity tests of the exudate to identify the causative agent that can inform the pharmacological therapy that will be used. We could also have a complete blood count, and this one normally shows that there is leukocytosis, okay, if acute otitis media is due to the bacteria. Number two, from laboratory go to imaging. So we could have radiography, which shows mastoid involvement. We could also be having diagnostic procedures like tympanometry. This one will show or detect hearing loss and evaluates the condition of the middle ear. Audiometry shows the degree of hearing loss, whereas pneumatic otoscopy may show decreased tympanic membrane mobility. What about the treatment? In treatment, we start with the general treatment. Whereas in general treatment, we are saying that in acute secretory otitis media, the Valsalva maneuver is performed several times per day, and it's possibly the only required treatment. Okay, we could also have concomitant treatment with underlying causes or elimination of Eustachian tube obstruction. In terms of medications, we can say that if it's a bacterial infections, we normally do the antibiotic therapy, and the first line drugs could be amoxicillin. If the patient is allergic to penicillins, since amoxicillin is a penicillin, we give them azithromycin, and this one is a microlid. Okay, remember this is the first line. Guys, a link will be popping up on the 15 different groups of antibiotics and the mode of mechanisms. Okay, great. So what is the second line drug? We could have cephalosporins, okay? We could also have amoxiclav, okay? Ceftriaxone, okay? Clarithromycin, erythromycin, or sulfamethoxazole trimethoprim as a second line. Guys, if you're working in Kenya, sulfamethoxazole trimethoprim is readily available, right? So that's why we prefer this one. Apart from the antibiotic therapy, we also have analgesics and antipyretics such as acetaminophen, okay, that is normally given, and possible treatment with antifungal medication if a fungal infection is identified on culture of the exudate, okay, especially for the recurrent infection. We could also have surgical intervention, surgery, guys. So the first one is maringotomy, okay, where a small incision is made through the tympanic membrane to drain fluid from the middle ear. Guys, a link will be popping up on these surgical interventions, showing or indicating the responsibilities of the nurses and how it's normally done. Okay. Number two, we have tympanostomy, okay, insertion. So we have tube placement of small tube through the tympanic membrane to allow continuous drainage of the fluid. We also have adenodectomy, where we have removal of the adenoids, which can obstruct the Eustachian tube and contribute to the ear infection. We also have the tympanoplasty, okay? So we have surgical repair of the tympanic membrane to address perforations or damage caused by chronic infections. We have the mastoidectomy, Okay, so we have removal of the infected mastid bone when mastitis has developed as a complication of otitis media. We could also be having ossiculoplasty, and this is reconstruction or replacement of the tiny bones in the middle ear to restore hearing function. Remember the ear ossicles? Yes? The Ms. Okay? Malleus Inca steps. Guys, and a song about the 206 bones will be popping up. You can still review the 206 bones, including the Ms, Malleus, Incas, and steps. We have cochlear implant as another surgical intervention, and here we have implantation of a device that directly stimulates the auditory nerve to address severe hearing loss. Okay, we also have the bone anchored acid, the BAHA, abbreviated as BAHA. So hearing implantation of the this is hearing implantation of the hearing aid. Okay, and this hearing aid transmits sound vibrations through bones for those with hearing problems. Lastly, we have the labyrinthectomy, and this is the removal of the inner ear's balance and hearing organs performed in cases of severe ear-related issues. Let's look at nursing consideration, guys. We'll start with nursing intervention. What are you supposed to do, guys? You're supposed to administer as an RN. You need to administer the medication and monitor their effect, starting from the antibiotics, okay, to the painkillers, okay? Great. Encourage the child and family to verbalize questions and feelings and concerns, okay, just to allay anxiety and to promote comfort. Actively listen and answer their questions honestly for therapeutic communication, guys. Guys, a link on therapeutic communication will be popping up. You can review and see the don'ts and the do's of therapeutic communication. We also need to provide emotional support, assist with the use of proper coping strategies. Okay, teach the child with the age appropriate and family how to properly participate in the treatment. Encourage the child and family to implement strategies to prevent recurrence, guys. Prepare the child and family for surgery if indicated. You need to consult with the child life specialist to provide age appropriate instruction and support. Okay, and then you need to collaborate with social services to provide counseling and community resources and support. Okay, so without hearing with hearing loss, okay, those with hearing, what are you supposed to do? You're supposed to offer reassurance that hearing loss caused by otitis media is temporary. Okay, so once treatment has been done, hearing can resume. Provide clear, concise explanation. You need to face the child when speaking, and you make sure that you are insuating the clearly and slowly so that they can be able to follow. Allow the time for the child to understand what you've said. In case the child is able to write, you can provide a pencil and a pen. Okay, so you need to alert the other staff about the child's communication problem so that they can be able to support. What about after the patient comes from laryngotomy? Okay, you administer prescribed medication and monitor their effect. You need to position the child to maintain drainage flow. Okay, and then you need to place sterile cotton loosely, okay, loosely in the external ear to absorb drainage and prevent infection. Change the cotton when it becomes dumpy. Avoid placing cotton or plugs deep into the ear canal. Change the dressing as needed and ordered. What are you supposed to monitor as an RN? The pain level and relief, okay, bleeding or any discharge, auditory acuity, ability to communicate the needs. Also need to monitor the postoperative status, including the drainage and dressings. Look at the signs and symptoms of an infection. Remember to watch for and immediately report pain and fever during acute secretory otitis media. So these are some of the nursing procedures that you're supposed to perform, okay, about from the pain and giving the medication. On the patient teaching, remember you are telling the patients about the disease and the parents, possible underlying causes, diagnosis and treatment. You're giving information about the disease, okay? You make sure that the signs and symptoms of acute otitis media such as pain and drainage, you will typically improve in 48 to 72 hours, so they have to know this. Otitis media with a fusion after acute episode usually resolves within 3 months. So prescribed medication, look at the dosages, indication, frequency, duration, expected results, potential effects, side effects. Remember to monitor for penicillin sensitivity, okay? And in that case, if that one is noted, you have to switch to microlid. There's also need for adequate fluid intake, special precaution for a child who has undergone maringectomy or rhinoplasty. Okay, there's need to use fitted earplugs for swimming, and the importance of notifying the doctor if a tube falls out or the child develops ear pain, fever, or pus-filled discharge. Remember to measure to prevent reoccurrence. Okay, so remember also to instruct the patient on how to administer otic drops. Guys, a link will be popping up on demonstrating how to administer the otic drops. Okay, but make sure you lie the child down with the affected ear facing up. Then you apply 2 to 5 drops. It depends with the amount that has been prescribed. You need to keep the child in the same position for 3 to 5 minutes after administration so that the drug can get in, okay? How to prevent otitis media? You say that for every child who is recovering from otitis media at home, teach the child and the family how to help prevent recurrence. Okay? Explain how to recognize upper respiratory tract infection and encourage early treatment. Discuss the risk factors and suggest changes to the family that they can make, such as avoiding exposure to secondhand smokers and weaning from pacifier use. Okay, if appropriate, you instruct the family to avoid feeding an infant in the supine position or putting the infant to bed with a bottle, because doing so would cause a reflux of the nasopharyngeal flora, resulting into otitis media. You also need to teach the child to promote Eustachian tube patency by performing Valsalva maneuver several times a day, especially during airplane. Okay, during airplane, you do the Valsalva maneuvers. After the tendinoplasty, advise the child to avoid use of nose blowing. Okay, so getting the ear wet when bathing, that should be avoided. Okay, remember to discharge the family, the child, the family involved. Okay, after you have explained all the teaching is related to these conditions. So guys, our question, we were having the child is diagnosed with right chronic otitis media. After the child returns from the laryngotomy and placement of the ear tubes, which intervention is appropriate? So the first response was apply gauze dressings. Number 2 was to position the child on the left side, position the child on the right side, and apply warm compress to the ear. Guys, so from the here, so we are able to narrow down to this one because they are contradicting each other. So one of it must be true. Yeah. Yes. So the child had right chronic otitis media. Place them on the right side. Okay. Place them on the right side. Okay. So the child should be positioned on the right side to facilitate drainage. Okay. So gauze dressing are not necessary after surgery. In fact, some physicians may prefer a loose cotton wink. Okay. The left side isn't the area for concern for drainage, and warm compresses may help to facilitate drainage when used on the affected and not none. Okay, thank you so much. So that is the presentation on otitis media. Remember, to access the free quiz in the description section of this video just to test your knowledge.